So I will talk about malformations of the posterior fossa. We have to answer to 6 questions regarding the fluid space, the tentorium, the cerebellum, the morphology of cerebellum and brainstem, the morphology of the fourth ventricle, and the signal intensity or echogenicity of the cerebellum. To answer these questions, 2 slices are required, and usually they lead to about 90 or 95% of the diagnosis. And as you can see, they concern both ultrasound and MR, and this is prenatal imaging, and this is postnatal imaging. First, I want to just start with some definitions. The orientation of the tentorium is the angle between this line at the posterior part of the tegmentum and this line at the proximal part of the tentorium. The insertion of the tentorium regards the position of the torcular, the distal portion of the tentorium. The Vernian axis, the tegmental Vernian angle is defined as the angle between the tegmentum and the Vernian axis. So we'll start with increased fluid space of the posterior fossa, and first the cisterna magna. When we acquire an axial view in ultrasound, we can see that here are the remnants of the Blake's pouch. Between this remnant, the fluid is anechoic, and because it is an intraaxial fluid in continuity with the fourth ventricle. The fluid that you can see on both parts of the Blake's pouch remnants correspond to the subarachnoid space, and this is the reason why this is slightly echogenic, because there are numerous vessels within the subarachnoid space. And you can see here the difference in echogenicity between the Blake's pouch remnant, which is here, and the cisterna magna, which corresponds to subarachnoid space. In cisterna magna, the orientation of the tentorium here, the insertion of the tentorium, the cerebellum, the brainstem, and the fourth ventricle are normal. The only abnormal or, well, unusual feature is enlargement of the subarachnoid space. It is, when it is isolated, it is considered a normal variant. In retrocerebellar arachnoid cyst, the orientation of the tentorium is normal. The insertion is not always normal. It depends on the size of the cyst. In this example, as you can see, the cyst is quite large, and this is the reason why there is a mass effect on the distal portion of the tentorium and an abnormal insertion. There may be, as in this example, a mass effect on the vermis, but it depends on the size of the cyst. The tegmental Vernian angle is normal, and there may be an occipital scalloping, not always, depending on the size of the cyst. But the cerebellum, the brainstem, and the fourth ventricle are normal, and also the tegmental Vernian angle is normal. As soon as there is concern for a retrocerebellar cyst, we must look for associated periventricular nodular heterotopia, because this association has been reported and is not fortuitous, particularly in female fetuses due to phylomin A mutation in girls. So, unlike what is written in the literature, it concerns the retrocerebellar cyst and not the cisterna magna. The Blake's pouch is characterized by a normal orientation of the tentorium. If the Blake's pouch is small, the insertion of the tentorium is normal as well. But the main feature is an increased tegmental vermion angle with a tail sign that you can see here, which corresponds to the superior border of the Blake's pouch. The vermis, the hemispheres, the brainstem are normal, and the fourth ventricle is enlarged. When the Blake's pouch is large, the orientation of the tentorium is normal, but the insertion is abnormal due to the mass effect exerted by the huge Blake's pouch. The tegmental vermion angle is increased, and there is a tail sign that we can see here on all these examples. This is the same features before birth and after birth. The vermis, the hemispheres, the brainstem are normal, and the fourth ventricle is enlarged. In Dandy-Walker malformation, what is very important is the abnormal orientation of the tentorium, unlike what is observed in Blake's pouch cyst. There is also an abnormal insertion of the tentorium, as you can see here, here, and here. There is a markedly increased tegmental vermion angle and also a tail sign. The vermis is abnormal. It is dysplastic. The hemispheres are usually also abnormal and small in size, and the brainstem also may be abnormal, not always. And there is a markedly enlarged fourth ventricle. So it is quite challenging to be able to differentiate a huge Blake's pouch, as in this example, and a Dandy-Walker malformation. It is important to be able to differentiate these two entities because the prognosis of a huge Blake's pouch is very good, while the prognosis of a Dandy-Walker malformation is usually poor. And the differentiation between these two diagnoses is based on all the characteristics I have mentioned. In the literature, some cases are shown as Dandy-Walker malformation with a normal clinical outcome. In retrospect, when we look at these images, we can see that the authors are not dealing with Dandy-Walker malformation, but with Blake's pouch cyst. Here are 2 or 3 examples of 3 children with a huge Blake's pouch cyst that we have seen prenatally and that now we follow up postnatally. All these 3 children have a normal development. I also want to show this new type of vermion cyst that we have described recently, and which is located in the horizontal fissure just below the primary fissure. It has a very good neurological prognosis. We can see here the prenatal appearance, and postnatally in our series, in about 50% of cases, the cyst has disappeared. We do not know exactly the nature of this cyst, but we can assume it is an arachnoid cyst. What is interesting is that it is always located in the same location. Now we move to another chapter, which is the decreased fluid space of the posterior fossa. And of course, when we see that there is no longer fluid in the posterior fossa, with this particular appearance of the cerebellar hemispheres that have been compared with a banana, and with the absence of visibility of the vermis, we are dealing with a Kyrie 2 malformation, which is observed in the setting of open dysraphism. It is characterized by a small posterior fossa, and downward displacement of the cerebellum, the brainstem, and the fourth ventricle, with a hindbrain herniation that you can see here into the foramen magnum and a beaked here tectal plate. Now we will talk about decreased biometry of the cerebellum. One hemisphere is decreased in size and may display abnormal echogenicity or signal intensity. Here you can see the same child before birth on ultrasound, MRI, and after birth. And you notice that one hemisphere here is normal, the other hemisphere is abnormal, and you see that the border is irregular. But what is very important is that vermis is normal. Usually these children display a normal outcome. Conversely, if the vermis is involved it is usually the result of an ischemic damage. If the vermis is injured, as in this case, the prognosis is very poor. This child, well, the parents of this fetus elected to terminate the pregnancy. The parents of this other child decided to continue the pregnancy. You can see here that the vermis is completely abnormal, and this child at the age of 6 presents with a psychomotor retardation. So it is very important to check the vermis. This is an example of a particular type of asymmetry of the cerebellar hemispheres that you can see here, that it displays a very specific pattern that we have described in this article and compared the cerebellum to a tilted telephone receiver. And you can see that in all cases, the features of the cerebellum are the same, and it corresponds to a face syndrome, which is, as you know, characterized by anomalies of the posterior fossa, hemangioma that appear usually in the hours following birth, arterial anomalies that usually are not seen prenatally, coarctation of aorta or cardiac defect, and eye abnormalities. Now we move to a bilateral decrease of the cerebellum hemisphere and sometimes also the vermis and the brainstem. And we will talk about pontocerebellar hyperplasia. The main first finding prenatally is usually decreased transverse cerebellar diameter. Because of a particular growth of the cerebellum before birth, it is mandatory to measure the transverse cerebellar diameter even in the 3rd trimester, because this malformation has a late onset. Unfortunately, many monogenic pontocerebellar hyperplasias are not discovered before birth because of this late onset. We have recently presented a large series of more than 40 cases of prenatal diagnosis of pontocerebellar hyperplasia. It is the first series which is published in the literature because only single cases of small series were published so far. The causes of pontocerebellar hyperplasias are numerous. It can be related to chromosomal anomalies, metabolic disorders, acquired disorders as in CMV, syndromic disorders with other anomalies, and we'll talk about tubulinopathies. And there are monogenic non-metabolic pontocerebellar hyperplasias with several genes described, including CAST. Here are some examples. The ultrasound was normal at 1st and 2nd trimester, and this woman was referred for enlarged fluid of the posterior fossa with intrauterine growth restriction, and we saw her at 34 weeks of gestation, and noticed that the transverse cerebellar diameter was very small, and we noticed that there was no bulge of the pons compared with the control, and a very small vermis. Look at the MR at the same on the same day. You can see that the brainstem and the vermis are very small, so are the cerebellar hemispheres, and all these findings were consistent with type 2 PCH, and it was a CASC mutation. This case is also interesting because it illustrates the progressive decrease in size of the cerebellum during the pregnancy. You can see that at 26 weeks of gestation, the transverse cerebellar diameter was normal. There was an enlargement of both lateral ventricles, and we couldn't see any bulge of the pons. Months later, you can see that it is quite, the GTC is at this 15th centile, and there is still a bilateral ventriculomegaly. And at 30, on the same day, the MR scan showed that there was no bulge of the pons. The parents elected to terminate the pregnancy a few weeks later. The legislation in France allows termination of pregnancy until the end of the pregnancy. There was a marked decrease in size of the brain weight and also the brainstem and cerebellar weight, a microcephaly, and it was related to a mutation of the PON-GNT1 gene in the setting of the dystroglicanopathy. Here is another example of abnormal morphology and biometry of the brainstem and cerebellum. This woman was referred for asymmetrical lateral ventricles without any enlargement. And when I did the ultrasound scan before MRI, because initially she was referred for MRI, I noticed that the corpus callosum was thin and short. The left olfactory sulcus was missing. There was a midline distortion. There was also a dysmorphic left frontal horn and a dysmorphic left basal ganglia, and asymmetry of both insula. All these findings were consistent with tubulinopathy, which was confirmed by MRI, which showed a finding which is so far impossible to show with the ultrasound. You can see here the typical asymmetry of the brainstem on an axial view, and you can see here that the bulge of the pons is abnormal. And you recognize, of course, the distortion of the midline, the absence of a left olfactory sulcus and bulbs, and the dysmorphic left horn, frontal horn with abnormal cortical with a dysphagia, which is a cortical abnormality. It was related to a 2BB3 mutation. And here are the typical findings of tubulinopathies that we've just talked about. And here there was also a partial agenesis of the corpus callosum. What is interesting regarding the posterior fossa is the brainstem asymmetry and also the absence of poor bulge of the pons. And also here notice the asymmetrical superior cerebellar peduncles. In these tubulinopathies, there are no extra cerebral anomalies. Here is another case of abnormal morphology of the cerebellum and the brainstem with also abnormal fourth ventricle. And you notice that on parasagittal view, you see here thickening and horizontalization of the superior cerebellar peduncles. And you have recognized the here. And also you notice that the vermis is completely abnormal. There is a vermin dysgenesis. So you have recognized the main features of Joubert syndrome with horizontalization and thickening of the superior cerebral peduncles, and also the abnormal shape of the fourth ventricle and the abnormal vermis. If we acquire axial views, we can see here a molar tooth sign, which is more prominent here on these postnatal MRI scan. You can see the thickening of the superior cerebellar peduncles, the abnormal shape of the fourth ventricle, the horizontalization and thickening of the superior cerebellar peduncles, the typical cleft of the vermis, which is visible both on coronal and axial views at the upper part of the vermis. So as you know, Joubert syndrome is a ciliopathy with a recessive autosomal inheritance, except for one X-linked gene, OFD1, and it is characterized, because it is a ciliopathy, by other abnormalities, extracerebral abnormalities, which can involve the kidneys, the eyes, the liver, and the limbs. Walker-Warburg syndrome is a type 2, listen carefully, and here are the main features of Walker-Warburg syndrome on prenatal ultrasound. Due to overmigration, there is thickening and marked echogenicity of the parenchyma between the enlarged ventricles and the cortex. There is also a gyra, ventriculomegaly, vermin dysgenesis, and a typical shape of the brainstem, which is called the kinked brainstem. There may be associated eyes abnormalities, as in this example, there was a unilateral cataract. The kinked brainstem is related to the persistent embryonic pontile flexure. It is mainly observed in this setting. And also, on the borders of this brainstem, you can see the echogenic bands related to over-migration. Several genes are involved in this alpha-dystroglycanopathy. It is the most severe autosomal recessive congenital muscular dystrophy, and it is associated with a very poor prognosis, with a severe global developmental delay and death in infancy. The prenatal diagnosis is possible on the basis of the imaging findings I have just shown. And of course, it is easier when there is a history of previous fetuses with marked ventriculomegaly. It is Walker-Warburg syndrome is one of the main causes of marked ventriculomegaly in fetuses. So you can see here MR, which was performed following termination of pregnancy, and you can see the typical shape of this kinked brainstem. Another case of abnormal vermin morphology. This woman was referred for MRI because of marked decreased transverse cerebellar diameter, and you can notice that the cerebellum is small in size, but you can also notice on this sagittal view that there is no bulge of the pons, and there is an abnormal shape of both the vermis and the brainstem. And when we perform MRI, you can see that there is a typical cap protruding into the fourth ventricle, absence of middle cerebral peduncles, and of course the biometry, both of the vermis and the cerebellar hemispheres, was abnormal. It is an example of a pontine segmental cap dysplasia, which is characterized by absence of bulge of the pons, shortening of the mesencephalous isthmus, dysmorphic upper and dorsal part of the pons with the cap protruding into the fourth ventricle, hyperplasia and dysplasia of the vermis, and usually the main ultrasound finding that suggests initially, well, that lead to search for these features is the decrease in size of the cerebellar diameter. This is another example of abnormal brainstem. It is the brainstem disconnection syndrome, which is very rare, which occurs at the level of the pons and the border between the pons and the mesencephalum, or the pons and the medulla oblongata. It is characterized by a cerebellar hypoplasia with cerebellar peduncles hypoplasia and microcephaly. The cause is unknown, but we've seen this example quite recently with a small cerebellum. MRI was performed because of the small cerebellum. What we can see here, that there was something abnormal with the heterogeneous mass at the level of the just before the pons. And you can see here that we observed both prenatally and postnatally, because this mother wanted to continue the pregnancy, that there is a kind of a disconnection of the brainstem, and we see here that the cause is the vascular disruption effect. As we have already said, ischemic disorder, for instance, in the setting of CMV, may be responsible for a small pons and brainstem, and also a small cerebellum, and cerebellar hypoplasia is a finding that may be observed in the setting of CMV infection. The last case is an abnormal cerebellar echogenicity or intensity with normal morphology and biometry. It is observed in capillary-venous developmental anomalies, and this is an example. You can see that there is an heterogeneous echogenicity of both one cerebellar hemisphere and the vermis. And you can see that we do not see any abnormality on T1 and T2 sequences, while if we use T2 gradient sequences, we see that there is a marked hypointensity. Before birth, we are not allowed to use contrast medium injection, but after birth, we could perfectly demonstrate that this was related to a capillary telangiectasia. So the messages are that the examination of the posterior fossa requires a systematic approach. Prenatally, as you have seen, many anomalies can be diagnosed using ultrasound only. Of course, MRI is more accurate than ultrasound, particularly for the brainstem. And MRI may be informative even in the second trimester of the pregnancy. As you have seen, many brainstem pathologies are associated with cerebellar abnormalities, and conversely, some cerebellar abnormalities must lead to brainstem or be associated with brainstem pathologies, so that as soon as we see a cerebellar anomaly, we have to thoroughly analyze the brainstem. And we have seen that some in utero acquired disorders may be difficult to differentiate from primitive developmental disorders. I thank you for your attention. Well, to the vermis, it may be very difficult to analyze properly the vermis, which is compressed, and we are unable to say that it is normal.
Thank you. Is there any point in suggesting follow-ups in these fetuses?
No. Usually, it doesn't help us to follow up because we face the same questions. And we have to use both ultrasound and MRI. It is very important to be familiar with these entities also with ultrasound, because we see much better the details of the vermis with ultrasound than with MRI.
Thank you very much. Are there any questions from the audience? We would like to encourage our online participants to set online questions. There is one question from the audience. What would you suggest as the optimal gestational age for fetal MRI when we are concerned for posterior fossa malformations?
I know that if I remember well, the deadline for termination of pregnancy in Greece is 24 weeks, isn't it?
That has changed recently. That has changed recently. So we have the opportunity to image later than the 24th week. Okay,
so it's much better. When I always say in France, because we are used to perform MRI at 32 weeks of gestation in order to analyze the cortex, what I always say is posterior fossa is an exception. As soon as we have concern for the posterior fossa, and we think there may be an abnormality, particularly of the brainstem, which is difficult to analyze on ultrasound, we can perform MRI as soon as 22 weeks of gestation. It can help a lot. As it is an ongoing process, you've seen that I've shown examples with a normal TCD, a transverse cerebellar diameter, initially at 22 weeks of gestation, and then it is smaller a month later. So we don't hesitate to perform another MR scan a month later if you cannot answer the question on the first scan.
Okay, thank you very much.
Thank you, Catherine. Merci beaucoup. On espère te voir plus souvent. Hein?
In Sevilla.
OK, parfait.